Thank you, Dr. Faryab Sana, uh, for giving me opportunity and space for to be chairperson of this very interesting topics today and very important topics today about the diabetic prevention program. Indeed, it is one of the most important issue nowadays as the prevalence of diabetes increasing day by day, globally as well as in South Asia country. So, cost if you think the cost effective aspect, probably the prevention is better than the being a diabetes and treating diabetes and the cost effectiveness. So we like to hear today from Dr. Villareol, the eminent speaker. Let me introduce him. He will speak. Can we stop the clock from clicking? Let me introduce Dr. Douglas Villareol. He's from the Bolivia. He's the professor of endocrinology and currently he's president of IDF South and Central America. He is also editor-in-chief, the renowned Voice, the publication from IDF, Diabetic Voice. With these few notes, I like to invite Dr. Douglas Villareal to start his deliberation on the prevention program on diabetes. Please, Douglas Villareal, over to you.
Thank you very much. It's such an honor to be present in this virtual Congress. I wish we could be present and be hugging you all good friends, but circumstances are not the best now. So we'll do it far away, but near with our hearts. Let me get the presentation, please. Okay. Diabetes and its complications, deaths, and societal costs have a huge and rapidly growing impact on the world. Between 2000 and 2025, the number of people living with diabetes will almost triple in some countries. Adults with diabetes have 50% of higher risk of death from any cause than adults without diabetes. In addition to risk for myriad complications, reducing this burden will require efforts on many fronts, from appropriate medical care to significant public health efforts and individual behaviors changes across the planet. Type 2 diabetes, previously referred to as adult onset or non-insulin independent diabetes, progresses from an early asymptomatic stage with insulin resistance to mild postprandial hyperglycemia to frank diabetes requiring pharmacological interventions. Understanding this natural history of type 2 diabetes will guide primary care providers in formulating effective treatments regimes that reflects the pathological difference between these stages of the disease. The optimal medication regime, when used in conjunction with dietary changes and exercise, will require modifications for each patient as the disease progresses. 7.2% Bolivians aged 19 and older reported being diagnosed with diabetes. As an interesting fact, it was observed that in the cities of higher altitude, there is a lower prevalence of diabetes than in the cities of lower altitude, as you can see in the image. The prevalence of obesity and overweight in Bolivia was 82.5% in people aged 18 and older. Weight gain, 70% of diabetes risk in Bolivia is attributable to or associated with excess weight. For every kilogram increase in weight over 10 years, type 2 risk, diabetes risk increases 4.5%. The prevalence of type 2 diabetes has increased rapidly in the recent decades, and the disease has become a major public health concern. The NHS and the NHS2, which follow a large number of participants during the evolution of the diabetes epidemic, have provided critical data to quantify the roles of diet, lifestyle, biomarkers, and genetics in the development of type 2 diabetes. There is a compelling evidence that excess adiposity is the single most important risk factor for type 2 diabetes. Thus, maintaining a healthy body weight and avoiding excess weight gain during adulthood are the cornerstone of diabetes prevention. Diet quality can contribute to diabetes prevention independent of body weight. The NHS data have contributed substantially to current dietary guidelines and policies that promote healthy eating. However, translating scientific evidence into practice require fundamental changes in public policies, the food industry, built environments, and healthcare systems. The Diabetes Prevention Program was a 27-center randomized clinical trial to determine whether interventions or pharmacological therapy, metformin, would prevent or delay the onset of diabetes in individuals with impaired glucose tolerance who are at high risk for the disease. Lifestyle interventions and metformin were effective in decreasing the incidence of diabetes. Lifestyle interventions decreased the incidence of type 2 diabetes by 58% compared with the 31% in the metformin treated group. Eligibility requirements were age 25 years or more, BMI 24 kilograms per square meter, 22 for Asian Americans, and impaired glucose tolerance plus a fasting plasma glucose of 95 to 125. Randomizations of participants into the DPP over 2.7 years ended in June of 1999. Baseline data for the three treatment groups: intensive lifestyle modification, standard care plus metformin, and standard care plus placebo, were presented for the 3,234 participants who were randomized. The lifestyle group participants initially lost the most weight, a mean of 7 kilograms by 1 year, but gradually regained, although still weighing about 2 kilograms less than they did at the randomization. The metformin group lost a mean of 2 to 5 kilograms during the DPP and maintained most of the weight loss. The placebo group mean weight loss was less than 1 kilogram from the DPP entry. So, medications may seem the easy way out, but lifestyle changes were more effective. DPP outcomes study followed these participants for an average of 10 years. And even after all the interventions were long over, the lifestyle intervention group continue to have a 34% lower rate of developing diabetes, so-called legacy effect. A total of 1,079 participants were aged of 25 to 80 years, 84, excuse me. A total of the 1,079 participants were aged 25, 80 years. In weight loss was the dominant predictor of reduced diabetes incidence. For every kilogram of weight loss, there was 60% reduction in risk adjusted for changes in diet and activity. Lower percentage of calories from fat and increased physical activity predicted weight loss. Increased physical activity was important to help sustain weight loss. Among 495 participants not meeting the weight loss goal at year one, those who achieved the physical activity goal had 44% lower diabetes incidence. At the end of the DPP conducted in 1996 to 2001, patients in the lifestyle intervention or metformin group were 58% and 31% less likely to have incident diabetes, respectively, than patients in the placebo group. Now, 22 years after they enrolled the DPP, patients were on average 72 years old, and those in the regional lifestyle intervention or metformin group were 25% and 18% less likely to have diabetes, respectively. And participants who did not develop diabetes had significant lower rate of eye, kidneys, and major cardiovascular disease at 57%, 37%, and 39% respectively. Individuals with impaired glucose tolerance have a high risk of developing type 2 diabetes. The purpose of this study was to determine whether diet and exercise interventions in those with impaired glucose tolerance may delay the development of type 2 diabetes, reduce the incidence of type 2 diabetes, and thereby reduce the overall incidence of diabetic complications, such as cardiovascular, renal, and retinal diseases, and the excess mortality attributable to these complications. In 90, the risk reduction in the incidence of diabetes type in the DPP was 31% by metformin and 58% by lifestyle. Excuse me. Just a second, please. Okay. In 1986, 660 men and women from 30 healthcare clinics in the city of Daqing, China, were screened for impaired glucose tolerance and type 2 diabetes. Of these individuals, 577 were classified using a World Health Organization criteria as having impaired glucose tolerance. Subjects were randomized by clinic into a clinical trial, either to a control group or to one of three active treatments group. Diet only, exercise only, or diet plus exercise. Follow-up evaluation examinations were conducted at 2 years interval over 6-year period to identify subjects who develop type 2 diabetes. The incidence of diabetes at 6 years adjusted for difference in baseline, BMI, and fasting glucose on the diet, exercise, and diet plus exercise interventions were associated with 31% and 46% and 42% reductions in risk of developing diabetes, respectively. Diet and/or exercise interventions led to a significant decrease in the incidence of diabetes over a 6-year period among those with impaired glucose tolerance. Individuals with impaired glucose tolerance have a high risk of developing type 2 diabetes. The Helsinki study of prevention of type 2 diabetes by changes in lifestyle in subjects with impaired glucose tolerance included 122 subjects, mean age 55 and mean BMI 30 impaired glucose tolerance, randomized control versus intensive lifestyle interventions. Individualized counseling aimed weight reductions and increased physical activities for 3.2 years. Weight loss, 3.5 lifestyle versus 0.8 kilograms at control at years 2. Weight reductions, more than 5%, 5% to 43% lifestyle versus 30% control. The diabetes cumulative incidence, 11% in lifestyle versus 23% for a risk reduction of 58%. The cumulative incidence of diabetes during the time when triglyceride was used according to treatment assignment. In the lower part of the image, we have the diabetes incidence rate, cases 100 persons years, with 95 confiability during the time when triglyceride was used according to treatment assignment. In the tripod triglyceride prevention of diabetes in women with previous gestational diabetes, the annual incidence of diabetes reduced from 12.1% to 5%. Overall, 56% reductions in development of diabetes. At 8 months after stopping drug, 50% of placebo patients and 2.3% of troglitazone patients had developed diabetes. Decrease in postprandial hyperglycemia with acarbose was associated with 49% relative risk reduction in the development of cardiovascular events and a 2.5% absolute risk reduction. Among cardiovascular events, the major reduction was in the risk of myocardial infarction. Acarbose was also associated with 34% relative risk reduction in the incidence of new cases of hypertension, even after adjusting for major risk factors. The reduction in the risk of cardiovascular events and hypertension associated with acarbose treatment was still statistically significant. The treatment with acarbose resulted in 25% reduction of risk of developing of diabetes. The DREAM diabetes reduction assessment with ramipril and rosiglitazone medication assessed treatment with rosiglitazone and or ramipril in 5,269 patients, multi-ethnic adult aged 30 years or more with impaired glucose tolerance and or impaired fasting glucose in a 2+2 factorial trial design. Follow-up was 3 to 5 years. The primary outcome was a new onset diabetes of all causes mortality. The secondary outcome was a composite cardiovascular events, myocardial infarction, stroke, cardiovascular death, revascularization, heart failure, angina, or ventricular arrhythmia requiring resuscitation. Renal events were the progression of normal or microalbuminuria to macroalbuminuria, or a 30% decrease in a creatinine clearance. Subsequent of the outcome assessment, there was a washout period during which placebo was assigned to all groups, allowing investigators to distinguish transitory glucose lowering from a more fundamental effect on diabetes development. At this time, fasting plasma glucose and A1C levels were assessed, and a final oral glucose tolerance tests were performed on participants with no diabetes. Rosiglitazone had a 60% relative risk reduction in new onset diabetes or death. Benefits observed regardless of ethnicity, sex, age, weight, and fat distribution. On this randomized double-blind placebo-controlled trial, the rosiglitazone statistically significantly reduced the incidence of new onset diabetes when given to patients diagnosed with prediabetes, but lacking a prior history of cardiovascular disease. The purpose of the Act Now study, a randomized double-blind placebo-controlled study, was to examine whether pioglitazone versus placebo can reduce the conversion rate or impair glucose tolerance to type 2 diabetes mellitus. A total of 602 patients were randomly assigned to receive pioglitazone or placebo. The median follow-up period was 2.4 years. Fasting glucose was measured quarterly and oral glucose tolerance tests were performed annually. Conversion to diabetes was confirmed on the basis of results of repeat testing. As compared with placebo, pioglitazone reduced the risk of conversion of impaired glucose tolerance to type 2 diabetes mellitus by 72%, but was associated with significant weight gain and edema. The HOPE study, which is the heart outcome prevention evaluation, was designed to determine if the angiotensin converting enzyme ACE inhibitor, ramipril, prevents cardiovascular events in high-risk patients. As people with diabetes have a high risk of such events, this group was specified for inclusion and analyzed in the HOPE studies. The HOPE study was designed to include up to 4,000 people with diabetes and was designed with a higher power to detect an 80% risk reduction in diabetes subgroup alone. A total of 3,577 individuals with diabetes were randomized to receive either 10 milligrams of ramipril or placebo. After a period of 5 years of follow-up, the group of patients receiving ramipril had a statistically and clinically significant risk reduction of 25% in the primary outcome of myocardial infarction, stroke, or cardiovascular death. This comprised a 37 risk reductions in cardiovascular death, a 22% risk reduction in myocardial infarction, and a 33% reductions in stroke, and a 24% reductions in all-cause mortality. The relative risk of developing diabetes among patients taking ramipril versus placebo was 0.66, which is a 95 confidence interval, a p less than 0.001. The summary of the efficacy of intervention to decrease the development of diabetes is displayed in these slides, in which we see the importance of the lifestyle changes and the impact that it has when it's implemented by person and by people with high-risk diabetes. We have other series of other medicines that have been studied. Some of them have been taken off the market because of cardiovascular risk, but we can see the lifestyle changes, and metformin is still a very important option. So, can we stop the clock from ticking? Yes, we can do that. But if we can't, we will end up taking so many medicines to treat so many diseases related to weight gains and diabetes. Thank you.